Hi, my name is Brittany Shannon, and my research question was, in clients with dementia, will music interventions improve quality of life? In my search, I found a moderate amount of literature available related to music therapy in dementia patients. However, only 2 articles used a measure for quality of life, and research lacked the utilization of occupational therapists to administer music therapy. In my first article, it was a level 2 study with a pre-test, post-test control with follow-up design using 3 randomly assigned groups. There were 120 nursing home residents recruited from 9 Italian institutions. Group A was a music therapy with standard care group, including 40 patients who received standard care and interaction with a music therapist. Group B was an individualized listening to music with standard care group, including 40 patients exposed to an individualized music playlist and listened to music in a quiet, private room with no interaction. The comparison intervention included 40 patients receiving daily standard care. All measures except the music therapy checklist were performed before, after, and 2 months after treatment. The music therapy checklist was used on 20 randomly selected patients to evaluate behavior during therapy. 200 sessions were observed. There was no statistical difference between treatment groups for behavior and psychological symptoms. However, each group showed a statistically significant improvement over time in measures for depression, behavior, and quality of life. In the music therapy checklist dementia analysis of 20 participants in the music therapy group, a positive but non-significant trend was found for an increase in positive behavior with clients. The limitations of this study include a large number of dropouts, no true control, a lack of definition of standard care, and a small overall number of music therapy sessions. The second study is a level 2 evidence with a pre-test, post-test control with follow-up design using 3 randomly assigned groups. Clients were 39 residents recruited from 4 group homes and 1 hospital. Group 1 was an interactive group with 13 participants. They received individualized music therapy selected by participants and family members from a CD player while interacting with a music facilitator. Group 2 was a passive group with 13 participants who received individualized music therapy from a CD player with no interaction. The comparison intervention group had 13 participants who were observed in their own room with 1 caregiver in a silent environment. The autonomic nerve index and FACES scale were used 5 minutes before and after intervention. The Behave 80 for behavioral symptoms was used 2 weeks prior, after 10-week intervention, and 3 weeks after final intervention. For the autonomic nerve index, both intervention groups showed significant differences in heart rate and heart frequency, indicating stress was reduced in participants. The control group did not have the same effects. In the FACES scale, both passive and interactive music groups showed statistically significant improvement in emotional state. In behavioral and psychological symptoms, the interactive music group showed significant improvement in more areas than passive music. The study found that both passive and interactive music interventions reduced stress and increased pleasant and emotional states immediately following intervention compared to the control group. The limitations of this study include a small sample size, no power analysis, and no evidence for using a 10-week length of treatment time. In the third article, it was a level 3 study with pre-test, post-test control with follow-up design using 2 randomly assigned groups. Clients were 30 residents from 1 nursing home with mild to moderate dementia. Music was selected through an interview or questionnaire with 15 patients who were then received music therapy through headphones in their room. Intervention was once a week for 20 minutes for 16 weeks. The comparison intervention group had 15 participants who were allowed to rest and read in their room. Outcome measures used at weeks 0, 4, 8, 16 during treatment, and week 24 as follow-up. Results showed that in music therapy group, anxiety levels were 60% better after 16 weeks of intervention, while the control group was only 4.3% better. In the depression scale, the music intervention groups improved by 47.1%, while the control group only improved by 1.7%. Limitations were that there was no true control, the care team was not described, and participants also received outside therapy and medications during the intervention period. Overall, current research shows that music therapy is beneficial for mitigating some behavioral components of dementia, such as anxiety, aggression, and depression that can impact patients' quality of life. Individualized music therapy is best, and music therapy should be utilized by occupational therapists as a treatment tool for patients with dementia. As occupational therapists, our main goal is to improve quality of life in our patients with dementia. This evidence shows that music therapy improves quality of life directly and also by decreasing behavioral symptoms such as depression and anxiety. Future research should focus on how music affects overall quality of life, including independence and functional activities, and it should look at how long-term treatment affects results as well. Thank you.